Hello everyone, my name is Kong Shrinani and welcome to my YouTube channel, Neuro Chat with AG. On this channel, I plan to cover topics that are closest to my heart and support the neurodiverse community. Topics related to neurodiversity, autism, late autism diagnosis, and autism in women and girls. I will interview thought leaders, esteemed researchers, scientists, professors, doctors, and psychologists and seek their views and updates on their latest work and research. I will also chat with parents of neurodiverse kids and adults and talk about experiences of neurodiverse individuals. Lastly, keeping inclusivity as a topmost priority. We might also discuss controversial disparate views for a collective understanding of issues and respect for diverse views. All the views and topics discussed are for informational purposes only. If you are interested in watching more quality content on this topic, please hit the subscribe button. Don't forget to press the bell icon to be notified whenever a new video is uploaded. Please also share the channel with your friends, family, and social media platforms. Thank you. Dr. Elizabeth Sheridan is the director of the clinical core at the A.J. Drexel Autism Institute and an associate professor at Drexel University. As a licensed clinical psychologist, she specializes in assessment and intervention for individuals with a range of developmental, learning, social, emotional, and behavioral differences, including autism. Dr. Sheridan is engaged in clinical research and training initiatives that aim to improve the quality of life for autistic individuals and their families. She earned her PhD in medical/clinical psychology from the University of Alabama at Birmingham and completed her internship training at the UNC School of Medicine TEACH program and postdoctoral training at Emory University's Marcus Autism Center. Dr. Sheridan's research focuses on the dissemination of best practices for autism, particularly in underserved communities. She's a co-principal investigator on Drexel University's Autism Center of Excellence PHASES grant, which examines public health strategies to improve outcomes for autistic individuals across the life course. Dr. Sheridan is dedicated to training other clinicians and researchers and is a certified trainer in evidence-based tools for autism, including the Autism Diagnostic Observation Schedule, 2nd edition, and Autism Diagnostic Interview, revised. Dr. Sheridan has advanced training in evidence-based intervention modalities and is an advocate for tailoring clinical support to incorporate an individual's specific strengths and values, with the goal of providing service that will optimize their quality of life. Dr. Sheridan, welcome and thank you very much for taking the time to do this today.
Thank you for inviting me.
And to jump straight into it, could you please share your background and what initially inspired you to pursue a career in clinical psychology and focus specifically on autism within that?
Sure. Yeah, so my love of working with children more broadly started when I was very young and babysitting. And I grew up with the idea that actually going to college, I was going to go to medical school to become a pediatrician. And that's one way I just thought it's a very straightforward way to take care of kids. I loved science and everything about just empirical research, and I thought a career in medicine would kind of check those boxes for me. So I went off to college at Wake Forest University in North Carolina, where I was a biology major, neuroscience minor. And actually, it was my junior year when I took a psychology class and started working with a young child on the spectrum. It was a posting that was actually just in the psychology building of our undergrad campus that asked for highly motivated people who liked working with kids that might be interested in working with a child with autism. And I pulled off one of those back in the day. We used to have to call people, and I pulled off one of those little numbers of the mother and connected with them and actually started working with this toddler who was minimally verbal at the time, had a fantastic group of interventionists working where I became one of the therapists for his home team. And so, in the course of doing that intervention, and really when we get into talking more about what I do, I didn't know at the time, this was, over 20 years ago now, but the team had crafted a beautiful behaviorally based but naturalistic play intervention for this child, or NDBI is the framework we now talk about, naturalistic developmental behavioral intervention. So I started working with this young man, and just it changed everything for me. I realized you could get a PhD in clinical psychology instead of going to be a pediatrician and serve these kids in different ways, but important ways. So that actually helped me pivot to change my major to psychology, which took a lot of work those last couple of years to catch up. But then I did a couple of things between then and grad school that set me up to work more with autistic folks. So I got a research assistantship at Vanderbilt right out of my undergrad time to help me get more real world clinical research experience before applying to grad school. And I did a Fulbright in Finland, which also was research focused with the idea that I would be going on to graduate school training. So that's how it all started for me.
Mhm. Thank you so much. And to expand more on that, so how did your experience as a Fulbright Fellow at the Finnish National Public Health Institute shape your approach to autism research and treatment?
Yeah, that's a good question. It's interesting to think about our life as kind of a winding road because I actually applied to be a Fulbright Fellow only because I did a summer internship in Winston-Salem that was really focused on basic science. So it was animal modeling for an anxiety disorder intervention. And so it turned out my mentor actually for that summer research experience that I applied to and matched into when I was thinking I was going to medical school, actually. It was that summer he saw I had several, the director of scholars at Wake had given me some different books of things like Fulbrights or Rhodes or other postgraduate fellowship studying things. And when he saw the Fulbright book actually on top, Vladimir was his name, he said, "Oh, I did a Fulbright. Are you interested in that? I can tell you all about it and connect you to folks." So it was a very windy path that I ended up connecting with a clinical psychologist who was actually American, who had been living in Finland for several decades, doing really exciting research at their National Public Health Institute. And I told him what my interests were, and there wasn't any real autism research happening at that time that he was connected to. But he did have anxiety disorder research that was ongoing that we wrote a proposal that eventually was funded that allowed me to go live in Helsinki as a Fulbright scholar and do research before graduate school. So it's interesting. I think about that a lot. I've actually had the opportunity to go back to Finland several times. Most recently, a couple of years ago, there was an autism conference in Stockholm, and I was able to get back over to Helsinki and still connect with some of those folks there. And it shaped me a lot. Like your question around specifically, I didn't do autism research that year, but what I did do was I learned how research happens. And this is something I tell all the trainees that work with me. And if you really are going to go down this graduate school path, having a really good understanding of what you're signing up for and working in a research lab and seeing how long it takes to do high quality science, from the crafting of an idea to the writing of a proposal and all the steps that go between you have an idea and then you present the paper or publish something on it. So that year was really formative in an academic sense in that way. But I also think I tell trainees and any, adolescent or young adult that I care about that I think traveling the world is just really important if you're able to take advantage of opportunities like fellowships or study abroad. Living in that flat when the Fulbright office is coordinated through the International Education Office in our country, and they set me up in international housing in Finland. I moved to a country at age 22 or 23, not knowing a single person except this mentor that I just met, and not knowing the language. I tried to learn some Finnish along the way, which is easier said than done. But honestly, that year opened up my eyes to just the world. And I just saw last summer my roommate from that year. I'm still very close to some of those folks. And that international education experience was really, really important.
You've also had a lot of experience training at a wide variety of some well-known autism programs. So, how have those experiences influenced your current work at Drexel University, and what do you think you learned from, you know, all of them?
Ooh, that's a big question. So I think from a journey perspective, again, going into this path, at least for me, knowing I wanted to train at the best places where autism clinical excellence, but also research was happening, I was prepared to move around a lot, and that's what I did. So you already heard I went from North Carolina to Nashville. So that research assistantship at Vanderbilt, I do think really helped propel me into the the more competitive applicants for graduate school. So I trained, as you mentioned, at UAB in Birmingham with just some wonderful mentors who really framed my understanding of the importance of not only high quality and evidence-based clinical work with families, both for assessment and intervention, but for also using that clinical work to inform our research questions and trying to think about ways that research can actually help families in real time. So that's why most of my research I've been involved in or grants I'm writing myself are very clinically focused with the idea that we want to serve families now. It's always good to have great groundbreaking research ideas that could have ripple effects for generations to come. But I think the clinical research, implementation science, figuring out what works for whom and how, that really actually started with my UAB graduate work. And then it was only reinforced through, the UNC Teach program you mentioned and the Emory Fellowship through their Marcus Autism Center. I think both of the mentors and work I did in those different training opportunities really helped me decide, number one, I like to do a lot of different things. And number two, I've got really incredible mentors and resources in the network I'm building to have these multi-site collaborations as well. So a lot of the work I'm doing now at Drexel is connected to colleagues, mentors, and friends from those five other places I've trained in the last, I mean, going on 20 years, I guess, if we count Wake Forest time. So I think one thing, again, with trainees, there's this idea, especially even for other healthcare providers that have, physicians or other specialties, you have to match, and potentially you can match in your geographic location at a program that works out great. But for me, I ended up, bouncing around really up and down the East Coast for the better part of a decade. To receive this specialized training, which in hindsight, I'm really grateful for, even though I'm very happy to now be in Philly for almost 5 years. So I don't anticipate moving anytime soon now that I've settled.
What you mentioned earlier, your research process now. So could you dive a little bit more into depth in that and explain what that whole process looks like and why the structure you have and follow is so important?
Absolutely. So I think, as I mentioned, I wear a lot of hats here. And so my role as director of the clinic in a research institute, I guess it helps to set up and describe how Drexel is structured. So there are several research program areas where there's principal investigators and researchers who are studying either a specific developmental stage of life or a specific area. So, for example, I have colleagues that are specifically interested in early detection and intervention. And so those are folks who are working primarily with young preschool, school-age kiddos. And those studies often require clinical expertise. So the idea that we want to have a really good understanding of someone's strengths, challenges, learning profile, developmental profile. And so they write myself and my team into the grants that are ongoing when it comes to anything that's clinical research. So a big part of my approach when it comes to research here at Drexel is thinking about where are the needs across the various teams. So I mentioned there's the early detection intervention. There's also a group specifically looking at environmental and potentially modifiable factors when it comes to how autism across the lifespan might be affected by things that folks come into everyday contact with, for example. And also there's a life course outcomes and policy and community advocacy group here. So across those really four different areas, they ask us as a clinical team to consult and contribute to their grants. So it's interesting because my role on those grants, I'm not the principal investigator driving the science questions often. However, that's shifted in the last year or two as my team's starting to write more grants that hit on what you mentioned related to service implementation practices. And so I think when you're explaining a specific approach, I can give one example that is just highly important to the work I do, not only in several different community-facing grants, but also our big NIH grant, which I think we're going to talk about soon. But is thinking about why is this question important? And if we find something meaningful, if we're looking for a difference between how an intervention works, for example, between a clinic setting versus a home setting or a specific modality or approach, is this going to matter to the end user or the stakeholder? So in order to drive that, I'm a huge proponent and have started, really integrating this into all talks that I do or trainings that I do, is thinking about how can we co-create and get feedback not only from autistic people themselves and folks on the spectrum that have lived that and walked that walk, but also from caregivers and family members and folks who know the experience of folks who maybe can't speak for themselves or tell us how that looks. So there's different terms used for that. So CPPR, community participatory research, and that framework, I think, is just one of the most important things that drives a lot of the work we're doing. And one example of that, I guess, to close this is, we're writing a foundation grant. It's a smaller amount of money than the big federal grants, for example. But in order for the foundation for this grant in particular to really succeed, we need buy-in from the local agency. So we want to see, how does this intervention that we know works really well in an academic medical setting? There's already been big randomized control trials on this parent coaching framework that show it works for certain, under these circumstances, which mostly the samples are often upper or middle class white folks, and that I think is one of the things from a diversity perspective. How can we actually see, okay, does this study or whatever the package of intervention strategies, we know that worked for this, group, does that generalize? Are we seeing that same effect in the community, especially when it comes to underserved or minoritized groups? And so that's something we're spending a lot of time thinking about, like getting out and partnering with those agencies and hearing from them. What are the feasibility implications here? Maybe why isn't it working? What are ways we could optimize this for you so it could be more successful in your group or with your families you're serving? So that's a big part of what drives how we conceptualize which research questions we want to ask and then what grants we're actually writing.
What role do you think public health plays in autism research, and how can initiatives like phases help bridge gaps in care and support for autistic individuals?
Wow, do we have all night? I'll talk all night about public health. So I think, especially the state of the world right now, where there's some kind of chaotic changes happening at a federal level around freezing of different grant mechanisms or thinking about the role that science plays in our society. And I will shout from the rooftops that I am among the biggest believers in science and the idea that we really need to use research frameworks in public health to better understand, with data driving the answers of what are the right decisions to make on policy levels in particular. So you referenced our ACE grant, our Autism Center of Excellence grant. The acronym for that is called PHASES, and it actually has public health. The reason it starts with PH is the acronym stands for Public Health and Autism Science, advancing equitable strategies across the life course. So that's a big mouthful. It's very common in autism research to have these long acronyms that hopefully summarize the spirit of that research or that project. But essentially, to summarize it briefly, PHASES employs a public health research framework to examine determinants, health services delivery, and health inequity, particularly for underrepresented or diverse populations, and what the impact of those factors is then on autistic people's health outcomes. So the researchers are essentially, we have three main research projects that look at this across the lifespan. So there's one group that's really looking specifically at that early detection and diagnosis in toddlers. Also, another, that kind of more middle adulthood time, thinking about patterns of co-occurring health conditions and health service uses for adolescents and young adults. And then finally, thinking about more specifically mental and physical health in older adulthood for autism. So, really, all three of these projects are taking a big data approach, the idea that we're not collecting data specifically for this grant, but rather leveraging information we already have from big state and federal data sets, things like Medicaid, Medicare, having access to that de-identified data to really ask these science and research driven questions in such a way that we can not only figure out what's happening and are there disparities. We know from research that's longstanding that autistic folks have worse outcomes across the life course when it comes to things like health and mental health. And those co-occurring conditions actually are more complicated and harder because healthcare providers often don't know how to support autistic patients, right? So the spirit of this research, the reason public health, PH, is the first two letters of this acronym is if we want to make change and see the needle move on some of these things, we need to do this with that public health lens, that we're thinking about systems. And I think that's why we're really grateful to have this Autism Center of Excellence grant to give us that opportunity to study this thoughtfully across 5 years. And my role on that study as a co-principal investigator, I co-lead our dissemination and outreach core for that grant. So I mentioned those three research projects. My job, along with my colleagues on our dissemination and outreach team, is to think with the researchers and our community advisory board members, even though this data is already collected. So we don't have the opportunity to sit down and co-create our research aims together, for example, with our community advisory board, but we do have the opportunity to hear from them about what are the things that are most important to you with your lived experience or your family's experience that we should be thinking about as we're looking at these data. And even though we already have a methodological framework by which we're trying to answer these questions, we're using that community driven co-creating model as a way to inform the work and the questions that we are asking as this project's underway. And we're in the process of even brainstorming what the revision and update to this grant might look like and how we could incorporate that lived experience even sooner. So that's something that we spend a good amount of time on and we're really proud of too.
What do you think some of the challenges are in, implementing these evidence-based practices for autism in community settings, especially in underserved populations? So I guess what are the challenges that, the involvement of public health you're trying to solve?
Yeah. Again, I'm trying to be brief, knowing we don't have all night, but I can actually give a very specific example of a call I was just on this week with one of our community providers. We're putting in a grant that I mentioned. We're looking at how this parent coaching framework is going to work within an agency that has a mandate. They're an early intervention provider in the community that serves a neighborhood, an area of Philadelphia that is incredibly under-resourced and the needs of the family. The clinical director, founder of this agency, described the needs of the families they serve as being so significant when it comes to just day-to-day living. So the idea of thinking about something like the Maslow's hierarchy of needs, where, that foundational layer of someone's well-being essentially is thinking about, do they have secure housing, food, water, like the basic things to live, right? And the idea is if in the real world, especially those underserved populations or community settings you referenced that maybe don't have the resources that other areas do, if you are so concerned about the safety of your child, of your family, wondering if you're getting evicted next week, it's very hard to know from a prioritization perspective how we can best help families in those instances. And we can go to them and say, hey, look, we've got this intervention. It's just an hour a week of your time and it's going to change your kid's life. And that sounds pretty straightforward, and we know this works and it might be effective in improving quality of life for you all. But if a family is so stressed and really challenging to even get to that 1 hour a week appointment, it really is a challenge then for, what's good enough when it comes to the quality of information. So, for example, if the research is all on an intervention that takes 12 weeks, but this family's saying, they would love to learn something, but they really only have a couple of weeks, or they have to, their time is so limited. That's our then something we're grappling with. And I know a lot of colleagues and researchers I know are thinking about things like, what's the impact we could have with a single session? Or what are interventions that are more modular? So instead of having this family trying to fit them into a box when they're really a circle, and the goodness of fit for best practices, quote unquote, isn't going to work for the reality of their day-to-day life. We as researchers and clinicians need to be thinking flexibly and to be really mindful of course, we want evidence-based practices disseminated, but at the end of the day, I think we as a field are sometimes losing people because they're saying, oh yeah, that's all well and good for you research people, or, I've heard the quote, ivory tower versus real world. Like, why is it that we can do this research and have these efficacy trials or effectiveness research that works in academia, but then we get out into the community and it's just a lot more complicated? And so I think I could probably talk for another 20 minutes about challenges, but to sum that up, I think for me, I'll go back to what I was talking about earlier, and that's this collaboration. When we think about community participatory research and evidence-based practices in community settings, hearing from the stakeholders who are involved. So whether that's the therapists themselves, the parents, the autistic people themselves, hearing from them what's working and what's not. And then we as scientists and researchers need to follow up. And when we hear something's not working, try to test something else. And it's just such a long, drawn out process to do this well. It takes a lot of time and funding, right? So I think it's one of those things. There are enormous challenges to do this well, but it's so important. And I think hopefully we can continue looking at that really carefully to just do the best we can over the course of thinking about not just the lifespan, but also serving all people, especially those who don't have resources.
You have advanced training in several intervention methods like the Ruby parent coaching and peers. So, what do you find to be the most effective approach when working with families and children with autism? And I know it's hard to like name one general thing. So, how do you approach figuring out what you think might be the most effective method?
Yeah, it's a good question. So for me, I am a big proponent. One of the first I mentioned to you, 20 plus years ago, I was doing a home-based program that really was framed in this naturalistic developmental behavioral intervention framework, NDBIs. And I personally, I'm trained and certified in a couple of different NDBIs. I think Early Start Denver model and Project Impact are two of the modes when I think about especially young children who are needing more structure and support around developing their social communication skills, I often think about it from a deficit and an excess perspective. And honestly, even the word deficit, it's so medical model driven. That's the world we're living in, where the medical model, frames autism as deficit disorder, impairment, dysfunction. There are all those words throughout the DSM, which, this book is kind of the guiding force by how we diagnose things. So when I think what the DSM language of deficit, or if we're talking in a more neurodiversity affirming way, the differences, right? So differences for young children that might not want to make eye contact, might not want to initiate with their peers, are perfectly happy to play on their own. How do we walk that line in a meaningful way to create a treatment plan that is affirming of that individual, but also building their skills so that they have the fundamental ability to communicate and to interact with the people they love and peers around them. And so I personally think that, there's several manualized interventions that really focus on that skill building, like the ESDM or Project Impact. And then there's other modalities. You mentioned peers. I actually got certified in peers quite a while ago and haven't had a chance to run those groups as often, but I do have more day-to-day implementation now with the Ruby parent coaching or research units on behavioral intervention is that acronym. And that's a good example of an evidence-based treatment. There's 11 core sessions to that. That's just a once a week parent mediated intervention where you're working directly with the caregiver, giving them strategies to then go practice at home and come back to you to problem solve and build. So when I think about evidence-based intervention tools, whether it's whatever the manual is, I think my bookshelf behind me has probably 50 different manuals I've collected over the last 2 decades. And regardless of what the session content is, I think it actually comes down to individualizing a treatment plan based on what the family's priorities and values and needs are at that time. And so for me, I'm grateful that I've had this advanced training across these different modalities for both skill building and skill reduction. So if there's interference or impairment when it comes to someone's challenging behaviors, for example, that's when the Ruby model might be really helpful. There's other groups like Facing Your Fears or that use cognitive behavioral therapy specifically modified or in the context of autism to support people with that evidence-based framework of cognitive behavioral therapy underneath it. So I always, when I'm training others and thinking about what interventions I'm pulling off the shelf, I want to get to know the family and hear about where are their other services and supports when it comes to, what are they getting at school? What are they doing day to day with other providers in the community? And then how can I, as someone who's trying to support them, augment or add to that using one of those evidence-based frameworks?
How do you, diving a little bit further into this, how do you tailor interventions to meet each person's individual strengths and needs? And can you give an example of how this personalized approach has made a difference? Maybe a situation where something that wasn't working for somebody, um, you were able to find a different way of doing things that end up a lot better.
Yeah, that's a really good question. So I think, that builds upon what I was just saying in the last question really nicely, in that there is something to be said for, in therapy or interventions, you hear about, quote, treatment plans, right? So what is the plan for us to work towards this goal of usually someone is seeking out treatment or therapy because something's not going as well as they hoped, right? So my goal with that is to sit down and to hear about, okay, where are the biggest challenges right now? What have you been doing to try to address those challenges? And then how's that worked for you? Because so often families will come in and say, I've already tried blank, whatever strategy. It just does not work. So they're going to go through their lived experience and share with me the things they've already tried or considered or not. But then I think it's up to us as therapists to really get creative sometimes if it's a trickier thing to manage. And one example, you asked for a specific example, and I'm smiling because actually the mother of this child, I'm very close still with that family I mentioned that I met in college. That young toddler with autism at the time is now in his mid-20s. So it's been really neat to watch him grow up. And, I have some loved ones on the spectrum, in my family and, godsons and friends' kids. So I've had this really unique opportunity to help people problem solve outside of doing therapy myself as a licensed clinician at a clinic. Honestly, some of the anecdotes or memories I have that I think bring to life what we do is I can think of both cases are kiddos who were struggling in some way out in the community or out in their school. And the work that we did both in sessions outside of those settings, but then my job, when you say, give an example of a personalized approach, often our job as the therapist is to support especially kids who are very distressed related to things like anxiety or things getting in their way behaviorally. The best way to do that is to show them that they can do it with your support, with your coaching, and then you fade that out over time. So, I mentioned already the intervention called Facing Your Fears. That's for children who have significantly interfering anxiety in addition to autism. So the anxiety of either a specific phobia, so one specific situation really makes them upset, and it's that one thing they want to avoid or not be near, Or it's more generalized anxiety where, going to big social settings or assemblies or parades are very overwhelming. And so the two examples that stick with me, the one I smiled about, was actually the little guy I worked with a long time ago had a real challenge with public restrooms and the idea of those self-flushing toilets that are they're alarming and can catch you off guard. And so even it generalized that fear started interfering so much that his mother wasn't, or his family wasn't really able to take him in community settings or places where those toilets might be because his fear, that irrational, that toilet is going to hurt me, because fear is a good thing, right? But the definition of anxiety is fear in the absence of real danger. So there's no real danger when we walk by a toilet that's flushing loudly, but we needed to teach him that. So to do that, we actually I'm smiling because the picture, his mother, again, he's now an adult, but when he was a kiddo, we took pictures of ourselves as therapists at the Target bathroom, a public bathroom, to be able to create a social story to show him all the steps involved from when we arrive at the store to when we leave, to use that as a buildup while we were working on anxiety and showing him that he can handle this and fighting back with facts, saying to himself, that toilet can't hurt me. That loud flush is very surprising, but it'll be over soon, right? So giving him a framework to have those helpful thoughts, which is an evidence-based strategy that's part of cognitive behavioral therapy, but it was our job to individualize that and to teach him that in a very structured and specific way. So we were able to, not only build that, take pictures and do a little video social story to show him before he even had to get to the store, but then walk him through that in a very gradual and thoughtful way so that we weren't flooding him with anxiety, but we were also coaching him and reassuring him that he could do that. So now, as an adult, thankfully, he can go, or actually, even as a child, he was then able to go back to Target or to go back to stores again, knowing that he might have to use those toilets that might flush very loudly, but it decreased that anxiety in a real meaningful way. So that outcome, I would argue it's even less about needing to, well, it's certainly wonderful to have the freedom to go to the bathroom wherever you need to, even if you're in a pinch at a store. But I would argue just even being able to have that family experience of going to shop at the store with your family again, made a quality of life improvement for them. And, it opened up his world in a way that was really important.
So you lead many training courses on evidence-based assessment in autism. So can you speak more about the impact of that training program for clinicians and the individuals they serve?
Of course. Training program at Drexel actually covers several different areas when we think about evidence-based assessment and intervention. We're fortunate that we're able to actually tailor content for the agency or group depending upon what they request of us. So a good example is this week is I actually went out to a big school district in the suburbs of Philadelphia and talked specifically to that group about how to navigate best practices when it comes to eligibility evaluations in schools. And actually, more than half of the room in that training had come to what I think, what I know is our biggest offering. And so a lot of people are seeking out training on a tool called the ADOS, or Autism Diagnostic Observation Schedule. So actually, I've been working as a trainer and doing outreach related to autism assessment for over a decade now. And when I moved to Philadelphia, I actually reached out to my colleague and friend down the road at the Children's Hospital of Philadelphia, Dr. Whitney Guthrie, because she was already providing ADOS trainings in the Philly area. And the demand is quite high. People really want to learn how to use this tool and more broadly, how to do autism assessment. So I reached out to Whitney, and unfortunately, it was at the height of COVID. I had moved to Philadelphia in the summer of 2020 when it was very unclear when we would be allowed to be gathering in person again for trainings. So we actually, after 6 months, realizing we're not going to be in person without masks anytime soon, we piloted this idea of doing a virtual training program. And these are full day trainings. So the clinical intro training for the ADOS is 2 full days from 9 to 5. And then there's an additional third day that's available for the toddler module for folks who work with very young children. And so given that, the demand was so high, we decided initially, honestly, when we were creating this program, we thought, no one wants to be on Zoom for 8 hours for across a whole day, much less 2 days or even 3 days. Like that's who's going to sign up for this. And much to our surprise, actually, a lot of people signed up and we sold out. I think we started quite small, piloting it. And over time, we've opened up more and more seats, but we do really cap it still because if there's hundreds of people in a Zoom room, it feels really hard to, get your question answered. So we keep the size actually quite similar to what an in-person training would be if we were to host it here or at CHOP. So somewhere between 50 and 100 people every time. We started out at 50, we've grown and capped it now because the demand is just so high. And the bottom line is, I feel really compelled every time I do a training to remind folks that we have really good tools. So rating scales, structured observation tools like the ADOS or some others that have been researched and studied, and we've thought a lot about, what is the goal of the information we're gathering. But at the end of the day, we still don't have one tool. We don't have the one answer in the rating scale or observations that's going to give us all the answers. And so it really is up to us as clinicians to empower others to seek out consultation training and ongoing learning when it comes to these tools. And so, we just analyzed our outreach of this training program. And since we founded this a few years ago, we've actually trained over 1,200 people from all around the world. We have someone from every state in the United States. So we've got all 50 states. We've had, I think, 24 countries at this point from almost every continent. So it's really interesting the impact of that. And then the follow-up we get to do with certain groups who, reach out and say, will you come and train our group here in, all over the country? I think that actually is one of my favorite things to do because we need more and more folks who really understand autism and who have that framework of thinking about not only what the medical model says so that we can open up doors so that families can get access to services and we don't have that bottleneck wait list issue that's been so pervasive for decades now, where you wonder if something's not quite right with your child's development or with yourself, and then you're told it's going to be 1 to 2 years before anyone can even help you. So my passion for disseminating these trainings and for doing so much outreach around evidence-based assessment is because it's our job to equip more clinicians to be doing that. So instead of me seeing that 100 kids, if I can train 100 people who each see 100 kids, that impact is so much broader. So I'm really grateful to build that we built that collaborative program, and that we continue to see the interest in the demand there.
That's something I'd never considered before, where the people who are doing this get trained. The Zoom thing has definitely made it easier to get a lot of trainings that I imagine, you'd have to maybe travel to places that knew about them before. So, in your opinion, what do you think the most critical societal changes are to support individuals with autism and their families better?
Yeah, I'm thinking a lot about this, especially in wake of some of the potential changes that we've been told could come at a federal level. Because at its core, one of the things I'm most happy to see when it comes to societal understanding of autism is even since I started really actively getting involved in this work at the beginning of, I guess, yeah, it's been over 20 years. So, in that 20 years, I've seen such a change from the stigma that historically came with an autism diagnosis to now this more neurodiversity affirming, understanding differences. And I think that actually is really important when it comes, especially to things like policy, advocacy, outreach, because unless people really understand what autism is and how different it can look, I think it's very confusing, especially for legislators and folks outside of healthcare to really understand how the two people that look so different in their presentation. So I have some folks on the spectrum who I love in my life, one of whom is in middle school and he has 130 something IQ and is doing really well academically. He has some social and behavioral challenges that have looked, different across his, 13 or so years. But then I compare him and my profile or what we think of, let's just call this guy Adam. So if I think about Adam in middle school, and then I have a family friend who has profound intellectual disabilities and autism, and she was actually diagnosed in the 1970s before we even had a true understanding. I mean, I know you've interviewed folks about the history of autism, right? So our understanding of what the DSM even says about autism, it's changed as a construct and how we define it and our understanding of what are these social and communication and behavioral differences. I think that actually right now there's a great deal of division actually about should autism all be lumped in that same way. So, my family friend who's now living in a group home in her 50s after being diagnosed, many decades ago, who will never live independently, will never hold a job, outside of the context in which she has support. She has the same diagnosis as this other middle schooler. And I think, you hear that a lot from, especially I have lots of patients or families I've cared for over the decades who have folks with very high support needs. And unfortunately, we've gotten into there's some semantics that are really important, and language matters, and the intentionality of language matters. And when I was training, we were told to only use person first language. So it's a person with autism. We would have never said, an autistic person or any of the other DSM, that identity first. But now in the last even decade, we've got a lot more data and feedback from autistic people who are saying, autism is part of my identity. It's definitely not something I want cured or treated or changed. And I want the society around me and the social world around me to be more accepting of my differences. And that's also juxtaposed against folks who have autism and other difficulties like intellectual disabilities or mental health co-occurring challenges, that they say autism is not a gift to me, or their families and caregivers are saying, I would want this gone or treated or changed tomorrow if I could, because there's such distress and impairment in my life. And so I'm really careful to listen to all of these perspectives because there's very much an us versus them. And, I think I'm hopeful to your critical societal change. My hope is that we can build bridges and that there can be this place of understanding and respecting other people's perspectives and their lived experiences, that the idea this isn't just a zero-sum game where, because I'm going to get more resources, that means it takes away from you. I think that drives a lot of the contentious and or challenges there. But my hope is that we can start framing these differences and get to a place where we can actually use the same vocabulary to understand everybody's strengths and challenges along the way.
What do you see as the next big frontier in autism research?
Oh, I've got a few. I think it's hard. I think and actually my answer might change if you ask me again next month, but the ones that are top of mind right now, I think technology, it's impossible to answer this question without thinking about the ways technology will potentially enhance not only the research we do, but also the experience of individuals and families. So I think a lot about, our center and several colleagues I know around the country have been part of testing or piloting new devices and technologies that are meant to aid in diagnostic processes. So the idea is, could a child or person watch an iPad and eye tracking data or other biometric output data? Could we use that to aid our clinical diagnosis? So, for example, children for whom autism is crystal clear, maybe they don't then need to be triaged or filtered onto that waiting list for the specialist that needs to really make that careful consideration with a longer diagnostic evaluation. So I think there's real potential. We need to be mindful and thoughtful about what are the limits of technology, because at the end of the day, I think regardless of how good a machine could be, I don't see a world in which we're eliminating clinicians who are helping families understand what these diagnoses mean and what specific intervention steps to take. But I do think there's real potential for having devices and or technology advances that will maximize efficiencies around diagnostics. So that's exciting. And also uncharted in some way. There's been a huge growth in that in the last decade in particular. But I'm also really excited about the idea. I think we have shifted at least in the autism research space to being a lot more mindful about having patient-centered outcomes. And instead of let's just do research to answer these questions that researchers think are interesting, let's have focus groups and have community advisory boards and make sure we're welcoming every perspective across the spectrum, not just folks who can speak for themselves, but also families and caregivers and alternative ways that folks might communicate using devices and augmentative or alternative communication. How do we get all of those perspectives to really influence what we do next? And, I've heard so much from families and people I care about the overwhelm of care coordination and how do we support families in their journey to find services and supports for their people that they love. And for me, I would love AI or some sort of technology to streamline that process for families so that we could just say, go to this service coordination resource and that they'll have, more hand-holding in the process with humans as opposed to wait lists and numbers that don't answer and, some of those challenges. So those are my, I think, top three for now, but next week that could change.
How do you envision the future of autism services evolving, particularly in terms of equity and accessibility for all families?
Gosh, it's hard to answer. And I think I am hopeful, I'm holding out hope that our country and federal powers that be will see the value in science that particularly we know for a fact there is data and bodies of research that suggest we have disparities in how and inequities across different groups in particular that have access to care across our country. And so I think I envision a future that I think a lot of the work that's been ongoing by colleagues and friends that is important work about intersectionality and thinking about not just autism, but how does someone's culture, background, their identity, both gender, ethnic, racial, all of those variables that bring richness to our understanding of how folks with autism are living their lives or optimizing quality of life. I think we need to continue those research projects and to have a better understanding in order to know how services are really working, having that research about equity and accessibility and how we build those bridges is essential. I'm also, if I have a pipe dream, one of the things I mentor a lot of medical students who have big dreams about changing the face of healthcare provider education. And, when physicians in training go to medical school at most medical schools around the country might have an hour, maybe two, of autism or intellectual disabilities or developmental disabilities in their curricula. And it's only those healthcare providers who specialize in certain disciplines like pediatrics or psychiatry or neurology that might get more advanced training. And the reality is autistic children grow up to be autistic adults, and there's a real healthcare barrier and healthcare provider comfort and effectiveness in navigating those patient journeys. So my hope is that there's some incredible work already ongoing around the country around healthcare access and using innovative models to train more healthcare providers. And that's something that we're very interested in doing as well.
We've come a long way. So, my last question. So, as a trainer for other clinicians, what advice would you give to professionals who are entering or want to enter the field of autism research or clinical practice today?
I do this a lot. So I have a few things here. I think it's actually one of my favorite things. I conceptualize the job I have. I do a lot of training of internal clinicians, and those are the folks who aspire to go on to be a clinician or a researcher in a variety of disciplines. So we have folks who are training to be behavioral interventionists, getting a BCBA, for example, folks who are wanting to be psychologists or various specialties within physician medicine, so different physician specialties. And I think regardless of your grad school goal, the number one thing I tell people before just saying, okay, I want to get a PhD in blank discipline, or I want to specialize in this in med school, I think going and actually spending some time with the folks you want to work with, either clinically or shadowing researchers who are doing that work, is super important. And I think, at the end of the day, I look actually on my desk, there's this little, it was a gift that was given to me, and it says, nothing is really work unless you would be rather be doing something else. And that's J.M. Barrie from Peter Pan. And so I think you need to decide as you are trying to, map out what you think you want to do when you grow up. Are you going to enjoy that? Are you going to find meaning in that? And especially if you want to be an autism researcher or a clinician focused in this field, you have to come into it knowing that it's lifelong learning, and that, we have to know what we don't know. And at the end of the day, being humble and acknowledging, like, I am constantly learning. Actually, the internal trainees I just mentioned teach me more when they're asking questions after an observation or bringing ideas for research that I hadn't even thought of. They're doing such exciting, important work, but I think you need to sign up for it with eyes wide open, knowing that grad school is long and hard often, but it's worth it at the end of the day. And to kind of close out, I think one of the things I often tell students, or folks that are just exploring this possibility, is it's a proverb actually that a mentor shared with me when she was giving me career advice early on in my faculty journey. And she said, if you want to go fast, go alone. If you want to go far, go together. And that has been especially important for me in autism research, and just true of my career. We talked about, I moved around, I think, 5 different times in 15 years to be with other people that were doing work that was exciting to me, or something that I would look forward to contributing to. And nearly every publication, grant, paper, training I'm most proud of has been done in collaboration with brilliant colleagues, mentors, and trainees too. And just that inspiration drawn from the families and the patients or participants we're serving in our work, but also being able to do that with other people you enjoy spending time with, has been huge for me, and makes me very grateful to do what I do.
Thank you so much. That's such an amazing message. Dr. Sheridan, thank you for sharing your experience and your insights. It was amazing to hear about, all the people you've impacted and all the amazing things you've done through your work. And I really appreciate you taking the time, to come here and engage, um, and share so many meaningful things in this conversation. Thank you so much.
Thank you for having me, and great work. I'm excited to contribute, and wish you all the best.
Thank you.